All right. It is 8 o'clock on the dot. I will turn it over to Roberta. She's going to speak tonight. Like I said, we're going to talk about normal gait and foot typing. Roberta is founder, owner, inventor of the Nolaro 24 orthotic system. They have QuadraSteps, they have little steps, they have a new line called tri-steps. She's also owner of a custom orthotic lab and pedorthic center, Stride Pedorthic Center. So we are very lucky to have her here tonight, and I am very appreciative of Nolaro's support and everything that they've helped us accomplish this year. And I am going to turn it over to Roberta. Thank you for being here.
Yeah, I'm excited to be here. I love talking about feet, as anyone who's heard me speak before. It's hard for me to say, everybody raise your hands. Let me see some emojis come up for people that have heard me speak before. And to this, oh yeah, I see it. So tonight we're going to be focusing on something that I actually don't think I spend enough time talking about, but what's normal, right? What is normal? Does normal even really exist? And I lecture with my partner, Lewis. He always says, all feet are bad. And I don't know if I agree with that 100%, but I do agree that there's a lot of problems out there. And so tonight I want to go back to basics, and I want to talk about how to look at a step cycle and how to recognize that there are all different kinds of feet in the world and that they all can't be assessed, or nor should they be treated the same way. So some of the things we're going to be talking about that affect how you would maybe design an orthotic is the effects of age related to the orthotic, and in certain cases, do we even need an orthotic? And other than the orthotic features, what kind of shoe are we going to put it in? That's always a hot topic. So this is me, and introduce me nicely. And so I'm going to forego this slide and get right into it. So are orthotics necessary? I see a lot of literature out there that says prefab orthotic or custom orthotics aren't any better than prefab orthotics. So I have some obviously biased opinions on that because I own my own custom laboratory, and I would tell you this about custom orthotics custom orthotic designs. It's basically like a computer, garbage in, garbage out. So a good orthotic starts with you. It starts with you understanding what you want or need, or your patient needs in an orthotic, and knowing how to communicate that information to your lab. Do I think custom orthotics, because I own a custom orthotic lab, you might say, do I treat everyone with a custom orthotic lab? Because I could. I make them myself for my patients, but I don't. Cost is always a factor for many patients. So I like to be able to provide over-the-counter and prefab orthotics, and I delineate between the two. So a prefab orthotic, like our QuadraStep system, which I'll get into a little bit tonight, is what I consider a medical grade prefabricated orthotic. We don't sell our QuadraStep orthotics online to patients unless they come to us with a prescription from one of you guys or one of our users. Some doctors love our products, but they're not allowed to sell things like nonprofit hospitals. So as long as they provide us a prescription, we will deliver at their request to a patient. But otherwise, we really feel strongly that this is just as good in many ways. These QuadraSteps are just as good in many ways as custom orthotics. So they need to be selected appropriately, and they're meant to be customized. So in our QuadraStep system, you'll see there's different color-coded orthotics that are associated with different foot types. I'll explain that as we go along. But tonight we're really going to be focusing on the blue group, the C quad. That's where the normal foot, the group that the normal foot falls into. And now I'm coming out, and I'll speak a little bit about this. I'm releasing a product called the tri-steps this month that is brand new, and it's my version of an over-the-counter orthotic. And yes, it will be sold online, but I'll tell you how we're going to do cost controlling with that so that you can deliver the orthotic to your patient cheaper than what we'll sell it for online. So to begin with, this is just a quick overview of my patent. I have a patent that identifies 24 naturally occurring or congenitally occurring foot types. And those foot types fall into 6 major color-coded groups. We color code them and letter code them because it's easier to teach that way. But basically, you want to think about it as a spectrum. In the 24 foot typing theory, or in the 6 major foot group theory, if you just want to break it down into 6 categories, it's not like you're an A or a C or an E. You could be a high A or a low A or a high C or a low C, you know, in that respect, or you could be kind of between the blue and the green. So your quad could be right here on the white line between the yellow and the blue, or maybe you're between the blue and the green, or this one gets really confusing, the one that's on the corner of the blue, green, red, and orange. So there are some crossover attributes, and it might sound complicated, but it's not really. It really, I'm going to teach you 4 steps to foot typing, and by the end of this presentation, even if you've never heard it before, you'll get the general idea what to do. But to navigate the chart, let's look at the yellow group is the highest arch of all. That's your pes cavus foot structure. The blue group, the group we're going to be talking about tonight, is your quote unquote quote normal or most neutral arch looking foot. The E quads are kind of moderately pronated. They're not flat, they're not normal, they're kind of in between in regard to arch height. And on the right side of the chart, we see blue is kind of planus, D is flatter and more splayed, and F is completely flat. So in terms of arch height, feet on the left side of the chart have an arch of some sort. Maybe the E's not that great, not that terrible either. And C's are kind of normal looking and A's are kind of high arches. But everybody on the right side of the chart has pretty flat feet. So let's take a look at the 4 steps to functional foot typing. And I hope you are my goal is to make you as excited about this as I am. I've been doing this for 30 years now, and I still get really excited. I had a really great experience at the office today. I saw a patient that came to me 25 years ago or so, before I came up with my foot typing algorithm. I was just collecting videos, and she's my number 12 foot type. This lady right here, this number 12 foot type. I saw her today, 30 years later, 25 years later, and I got to video her again, so I'm really excited about that. So, I know I'm a goober. What can I say? So, step 1, we're going to look at arch heights. Now, I always tell everybody when you're looking at feet, don't put all your eggs in the arch basket. Yes, it's good to look at arch height, but we can't just put everything, all of our assumptions on foot functioning just based on arch height. I always say the runner's world wet test is all wet. You can't tell everything about function based on arch height, but it's a good place to start. So A quads, we know, pes cavus, you've seen that foot. It's like your Charcot-Marie tooth kind of high arch, really aggressively high arches. C's are kind of more normal looking arches, but we're going to find out not all C's are as normal as others. And the E quad is moderately pronated, and the B's are flat, flatter, and flattest. So the first thing you're going to ask yourself when you see a patient standing in front of you is, do they have an arch? Do they have a medium to high arch foot? If the answer is yes, my patient I'm looking at now has a medium to high arch foot, then we've already eliminated most of the foot types. We have 2 foot groups left. That's only 8 out of the 24 left to choose from. So the name of the foot typing game is the process of elimination. So if you see a patient has a pronating arch, we know the major pronators are on the right side of the chart, but E's are technically pronators too. So in about 5 seconds, you should be able to reduce your choices to 2, has an arch, to the other 4, has a less than satisfactory arch. All right. Next thing we're going to do is think about why. Why is that? So let's play this video here that I'm going to show you. And we've seen this a million times. This is a patient who I'm asking to go ahead and supinate and then relax, and then supinate and relax. And you'll see as they pronate, a lot of really bad things happen. Their heels roll into valgus. The arch collapses. There's strain on the deltoid ligament, the posterior tibial ligament. But don't forget to look at the lateral side of the foot. That's the most often ignored or overlooked part of the foot. When this foot is pronating, the pressure is initially being exerted on the lateral column. So that poor fifth ray is getting dorsiflex. It's getting pushed into a dorsiflex position, which makes the calcaneal cuboid joint unstable, which then means the peroneus longus no longer has a functioning pulley system because it lost the integrity of the lateral column. So now the peroneus longus can't stabilize the base of the first metatarsal. So now we have an unstable first ray that you'll see the ground will then easily push the first ray into dorsiflexion. And we see a lot of people with these really flat feet, and we say, oh, they have a dropped second and third metatarsal because they get callousing there. But is it really? Did the second and third drop, or did the first and the fifth get pushed up? I think that's what's happening. The first gets pushed up, then the lateral column is unstable, and then the medial side of the foot gets pushed up. So that's your pronator. We're not talking about that foot type tonight, but I thought it would be good to review that. This foot type is the one we're talking about, the foot type C, and this will also apply to the A category. These people are on the left side of the chart. That means even if they wanted to, they can't pronate a lot. They can pronate maybe little to none, or maybe mild to moderately. So let's watch this. Let's watch this patient who has what's called an uncompensated rearfoot varus. That means that when they go into their maximally pronated position, they're basically still supinated. And so I like to joke with these people, and people have probably heard me say this before. I'll tell my patients, I'll give you $100 if you can put your arches on the ground. I'm going to freeze this video in a second, where this guy is really, really, really trying to get my $100. And you can give this guy the $100. So we can see this patient's arch, no matter how hard they try to pronate, they're lifting the whole lateral side of their foot off of the ground, trying to force this arch to pronate, and it still won't come down. Now, some feet in this C and the A category will be more like that. Some will pronate moderately, like we'll see in the quote unquote, the more normal looking arches. But your cavus, all your A quads, and 2 of the feet in the C quad, they're really not going to be able to pronate all that much. So if you're not following that, hang on, because I got a lot of slides that will bring it to light. So the basic premise here is the C quad falls into the category that's uncompensated in the rear foot. And that means the subtalar joint is unable to go into, to pronate to a vertical heel position or a valgus heel position. In its most pronated position, the heel will still remain moderately inverted. So when we're doing the next step to functional foot typing, we're looking at the rows, and the rows are controlled by the forefoot. The C quad and the D quad have a neutral forefoot. So that means when they're taking a step and their forefoot comes down to the ground, it loads evenly across all of the metatarsals, all at the same time. And even under load, that forefoot will splay a little bit, but in the C quad, that's one we're going to focus on tonight. It's not going to splay a lot because the heel remains inverted. And when the heel in its maximally pronated position remains inverted, that means the midfoot is locked and stable, okay? As in comparison to the D quad, the heel could pronate to a vertical position, and when that happens, the midfoot becomes unlocked. And that means under the mass of their body, that arch is going to collapse, and we're going to see a lot of foot splay. So here's the D quad, loads evenly just like the C quad, but then it drops and splays like a plunger. The bottom row of the chart is going to be for forefoot varuses, and we're not going to dwell on this today, but a forefoot varus causes abduction of the forefoot, or what we call too many toe sign, or too many toes laterally. And you'll notice you can't see the big toe medially. And the opposite of that on the top row is the forefoot valgus. And a forefoot valgus does the exact opposite. It draws your toes inward, and you end up with what I call a peekaboo toe, where you see too much of the hallux medially, and you're losing sight of the lesser toes laterally. So to summarize this, and I usually like to do this as a Q&A and get people involved, but imagine this. You have a patient standing in front of you. You have the shoes and socks off, you have them march in place, and have them come to a nice relaxed standing position, so not subtalar neutral, all in their relaxed resting calcaneal position. And you look at that patient's foot and you say, my goodness, this patient has a pronating arch. And when I go behind them and I look at their toe sign, I see it's neutral. So a pronating arch, let's start there. A pronating arch is one of these four groups. And a neutral toe sign is the middle row. So that person has to be a D quad. A D quad is a person who pronates and their foot splays out, but in the end, we see toes on both sides of the foot. A C quad is a little bit different because in its maxillary pronated position, as I keep saying, they're still somewhat supinated. This heel is still inverted 4 or 5 degrees. So when that happens, we're still in the middle row, which means the forefoot's neutral and comes down and loads evenly. So that person still exhibits a neutral toe sign. So the difference between a C and the D, whether you have a planus splay foot, like the Fred Flintstone foot we like to call this foot, or the C quad foot, where we have a better arch, is really completely controlled by the rear foot. And we're going to be focusing on the rear foot tonight. Really quickly, the B quad has a pronated arch and a peekaboo toe, so we see too much of the big toe medially. The A quad is a high arch with a peekaboo toe. And E's and F's are both in the pronating group, and they both have too many toes laterally. So we differentiate an E from an F based on severity. And F quad, you know that foot when you see it. You're a podiatrist. You know this foot, PTs, podiatrists, I don't care. Anyone who treats people with flat feet knows this foot. There's significant posterior tib and deltoid strain. There's a lot of forefoot abduction, heel valgus. This is a patient that you're going to see in your office all the time because they know they have very bad feet. But in E quad, when they're in their maxillary pronate position, although I know it doesn't look like that on this video, the infracalcaneal fat pad kind of wraps around to the lateral side of the heel and gives the appearance of it being in a valgus position. But really, if you were to really inspect that and get down and feel the calcaneus, you'll see that heel usually gets hung up slightly shy of vertical, maybe 1 degree, 2 degrees. So it will pronate as far as it can go, but in the end, we're going to see a lot of arch shelving where the arch drifts medially and forefoot abduction. So E's and F's are much more pronated, much more heel valgus, much more posterior tib strain than you'll see with an E quad. So I think it's important to go over those so you know there's a difference between all these feet, and not all feet are quote unquote normal. In fact, we're narrowing it down to 1 out of 24 feet is normal. And do we even see that in the adult population? Stay tuned, we're coming to that. So tonight we're going to be watching videos of people in the C quad. I want you to know, if you've never heard this stuff before, can I see some emojis for people who have never heard any of this conversation or this type of topic before about functional gait assessment? So okay, a couple newcomers. All right, I'd love to have that. So A's, C's, B's, D's, E's, F's, they all have their own unique way of walking. A quads walk like they're on a tightrope, 1 foot right in front of the other. C's walk like a duck with their toes pointing outward. B's are in-toe walkers. D's are your Fred Flintstone foot, and they have a lot of midfoot breakdown. E's we call the runway model because they have medial heel whips. And F quads, they have kind of a waddling gait, and we call those the failed foot. We have another adjective we use when we're not in a public place, but those 6 groups of feet, completely different. So it sounds complicated, but there's 6 gait patterns, 6 basic gait patterns, and then you learn how to fine tune them. I'm going to teach you the basic foot pattern of the C and how to fine tune it in this lecture tonight. The other thing you're going to notice is that they each have their own callus pattern, and they each have their own unique set of symptoms. So the C quad we're going to be looking at has hip pain, Haglund's deformity, lower back pain, iliotibial band syndrome, and they get a callus of the big toe on the medial side. We're going to explain all of that's going to be demystified in the next 30 minutes. I will also tell you that they're not all as common. So the C quads are about 28% of the population. And this is where we need to be more patient advocates, because some of the primary symptoms the C quad is going to have are hip and back pain, not foot pain. Okay, they will have foot pain. Anybody can get plantar fasciitis. They do have Haglund's deformity. They do get lateral and social Achilles tendonitis. But the majority of the C quads that you see are going to have iliotibial band syndrome, piriformis syndrome, low back pain, gluteal pain, mechanical back pain because of the way they walk. And you'll understand why. So you start, one way to do some internal marketing in your office is, hey, patients, did you know your hip pain, knee pain, shin pain, back pain, heck, even neck pain can be coming from the way you stand and walk, and I can help you with the right orthotic. So this is just kind of a schematic layout of the 24-foot type chart. We're not going to dive into this. This is part of my master's class program. Any of you come to my master's class? Any more people? Show of hands of anybody who's come to the master's class. But we're going to be talking about this row right here, 9 and 10. Well, the row is 9, 10, 11, and 12, but we're going to be focusing on the root, the 4 root deformities are controlled by the rear foot, foot types 9, 10, 11, and 12. We're going to cover the 9 and 10, and we're going to also cover the 13, 14. Let me go to the next slide because you'll see those feet a little bit bigger. Foot types 9, 10, 11, and 12. What do they have in common? They all have a neutral forefoot. So their entire gait cycle is exclusively controlled by what the rear foot can or cannot do. And on the left side of the chart for the blue feet, the foot types 9 and 10, they can't pronate. They can pronate, this foot can pronate, the 10 can pronate a couple degrees, a few degrees, but even in its most maximally pronated position, it's still inverted. Yay, that's not a bad thing, that's a good thing. So let's take a look at 9, 10, 11, and 12. On the right side of the chart, that foot type 12, they can freely pronate. They typically have hypermobility in this patient population. They pronate, their arch drops down, there's a lot of splaying, and their heel goes in freely into a valgus. They are what's called a compensated rearfoot varus. They can pronate at the subtalar joint, no problem at all, and that's not a good thing. Foot type 11 is a little bit better because in its maximally pronated position, it's still inverted a couple degrees, 1, 2, 3 degrees, still inverted in its maximally pronated position. The 10, think of the number 10, and it's always the best number, right? I'm a 10. So if you're a number 10, when you're in your maximally pronated position, you're still inverted 4 or 5 degrees, and that is ideal. So the number 10 is I won't call it the normal, I will call it the ideal foot. The ideal foot is a foot that remains partially inverted. So we're not uncompensated. We're not totally uncompensated or totally compensated. We're partially compensated. And it's like the 3 little bears. This mattress is just the right one. So when your maximally pronated position keeps you inverted 4 or 5 degrees, that's going to be enough to keep the midfoot locked under the weight of a normal size adult. Now, if I have a perfect, ideal number 10 foot and I weigh 400 pounds, that arch is going to come down, okay? Or trauma, or mileage, aging. Things are going to destroy this arch. And for that reason, I've been looking at feet for 30 years. I've done a lot of studies. I did a study on a group of 1,000 Coast Guard cadets. And in those 1,000 Coast Guard cadets who were in prime physical shape, 18 to 21 years old, I only found a handful of 10s. You know why? Because I think they only exist in children. Gravity starts taking over when you take on your adult body shape. If you're a child and you weigh 35, 45, 65, 85, 100, 105 pounds, you can be a 10. But once you take some thousands and thousands of steps day after day after day, and you join 16 sports teams, and you have injuries and gravity, the arch starts to compress, so 10s don't stay 10s very long. The number 9 foot type, that's the one that we're going to see a lot. The number 9 is the most common of the 4 feet in the C quad group, in the quote unquote normal group. The C quad is inverted more than the ideal 4 or 5 position, 4 or 5 degrees. It could be 6, 7, 8, 9, 10, 11, 12, 13. I've seen as much as 12 or 13. I've rarely seen anything higher than that, except for weird extreme cases. But in the normal population, you're going to see a lot of people that are uncompensated minus 7, 8, 9 degrees or so. Lots of heel inversion. So if your heel is inverted, your arch is going to be just a little too rigid. You're going to lose your ability to pronate at all. And so you won't have the ability to absorb shock, which subtalar joint is supposed to pronate. It's supposed to pronate so you can absorb shock. And so the rear foot position in the number 10 foot type allows some of that pronation to occur, which means we can attenuate shock, but in the 9, not going to happen. So let's see what happens. When your heel is everted, your arch drops down. But as you start to invert your heel, you'll see the arch gets a little bit better. And in the number 10, we have kind of a normal height arch. And when you get to the number 9, where you're too inverted at the heel, then your arch gets maybe a little subtle cavus looking. So the other thing you'll notice is that as we go from the 12 to 11 to the 10 to the 9, the tibia is less internally rotated. So in the number 12, it's like a corkscrew. When you pronate, your tibia internally rotates. So the number 11 still has some tibial internal rotation, but in the 10, it's in a great position. And in a 9, it's almost too laterally rotated, too externally rotated. And how can you tell that? By looking at the pitch, the angle from the medial to the lateral malleolus. The more pronated you are, the more horizontal this becomes. The more supinated you are, the more oblique the medial malleolus is, much higher than the lateral. One other thing you're going to notice about the 9, 10, 11, and 12 is they all have a neutral toe sign. I can see the big toe medially on all of these, and I can see some of the toes, lesser toes laterally. So they all have kind of a neutral toe sign because they're all in the same row. 9, 10, 11, 12 are all the same row right here, neutral forefoot. So the only thing different between those 4 feet is how the rear foot functions. So let's focus with the 4 feet, because that's what tonight's all about, the normal foot, the 4 feet on the left side of the chart. So the John Wayne walker, this is what we call the John Wayne walker. One thing I will point out is that, and I'm going to peek ahead a little bit, the number 9 is the most common of the 4 foot types in the C quad. So out of that 28%, you're probably going to see 60% of them are going to be number 9s. So we call this person the John Wayne walker. And we call them the John Wayne walker, let me put up the video, because they walk like a duck. They walk with 1 foot going east and 1 foot going west. Howdy, partner. So the other thing you'll notice is if you look at the deck of the treadmill, you'll see the deck of the treadmill is bouncing up and down. And that's because they can't pronate adequately. This is the number 9 foot type, not the number 10. So I should preface this. This foot type is the number 9, the one that's the most common, not the most ideal. So let's start here so you can get a comparison. So when I watch the number 9 foot walk, you're going to see, because the heel is super inverted, we're way on the left side of the chart. We've got a lot of loading on the lateral column of the foot. You can see that oblique angle I was talking about between the medial and the lateral malleolus. Even though you can't see the arch, that would make me suspect that it's a pretty full arch because of that angulation. Also, because the heel is inverted, there's going to be a constant tug on the lateral Achilles. So we will see the presence of lateral insertional Achilles tendonitis, and we'll see Haglund's deformities happening in this foot type. The other thing you'll notice is that as you go into mid stance, the arch remains pretty darn stable. It's not collapsing at all. And you can tell because the heel's staying wickedly inverted, and that angle doesn't change at all. And so the other thing you're going to notice is that when the heel comes up off the ground, let me go to the right foot because I think the lighting is better on this foot. When the heel comes up off the ground, we see a nice stable lateral border. If you're not following that, you'll see when the heel comes up off the ground, the whole foot rises as a unit. I'll show you later one that doesn't, okay? So because the heel's inverted, and that in turn locks the midfoot, that means the lateral column of the foot is stable. That means the peroneals can do a pretty good job. Now, when we go into propulsion, we're not propelling straight forward over our foot. We're not going into across the whole plane of the forefoot and propelling forward. We're kind of pronating off of an out-toed foot. So our final propulsion is going to be on the medial aspect of the hallux and the medial aspect of the first MTP joint. So what do you think you're going to see there? Of course, callusing. So let's go ahead and take a peek at that. We're seeing a big pinch callus. A lot of times you'll see a crescent callus, but notice there's no thickening of the skin under the first med head. And that's because this poor puppy never touches the ground because the heels are so inverted, it's lifting the whole medial column of the foot off the ground. They'll tend to wear their shoes out laterally because of that gait cycle. And there's that Haglund's deformity. They walk like a duck. So let's go back now and think about what will that do to a person who walks like that. And again, we're emphasizing right now the C quad number 9, which is not the ideal foot. We'll get to that one, but you have to compare all the feet into that C quad group. So when this person's walking, they're always walking with their feet turned out. It's the only way they can ever get the medial side of their foot to load to the ground. Because if they stood with their foot straight in a linear position, because they can't pronate, they wouldn't be able to load the medial column. The only way they can load the medial column is to stand outward and gain compensatory motion at the knee and the hip, the pelvis, and the back. And that is why all their symptoms are more proximal. Hip pain, lower back pain, iliotibial band syndrome, and yes, lateral Achilles insertional tendonitis, retrocalcaneal heel pain, Haglund's deformity, all that stuff can happen at the heel, but it's not as common as the other stuff. So what are we going to do about this? What are we going to ask of our orthotic? How is an orthotic going to help this patient? And so what you want to do is ask yourself a bunch of whys. Why is this patient having IT band pain or lower back pain or Haglund's deformity? Well, because they walk like a duck. And for all these years, that lateral Achilles has been getting really tight, and it's always tugging on the posterior aspect of the calcaneus, and now it's developed this bony proliferation, and the IT bands are tight, and the piriformis is tight. Well, why do they walk like that? Well, it's just the way they were born. They have an uncompensated rearfoot varus, which is keeping that heel too inverted to the ground, so they have to walk like a duck to get the arches down. So now we know what we want the orthotic to do for us. We want that orthotic to get that patient to walk straighter. And how are we going to do that? We're going to bring the ground up to the foot. So I know you've all heard the terms intrinsic and extrinsic posting. The custom orthotic that you make for this patient, or in our QuadraStep, this is a QuadraStep prefab system. This is part of our QuadraStep education. So you're going to see a lot of prefab pictures. Never mind, you can do the exact same thing on your custom orthotics. You just need to know what to ask for. I want to post this rear foot intrinsically about 4 degrees, 3, 4, 5 degrees. It doesn't matter. Just get some support to the medial heel by bringing the ground up to the foot. We're not extrinsically posting it. Extrinsic posting would mean we would be adding wedging and tipping their foot into more inversion. We don't want to do that. They're already inverted. All we want to do is eliminate the need for them to toe out by giving them something to land on. So a nice arch support, a little bit of medial rear foot posting will help them load the medial column of the foot without having to out toe. All right, so that's the nature of the basic orthotic for the C quad, the most common C quad, the foot type number 9. This is kind of fun. I tell people, I tell my students this. I have a lot of people that come in and see patients with me. And I'll say, we're going to put this patient in subtalar neutral and then tell them to relax. But don't blink because you might miss the whole event. If I look at this foot, here's a patient that's a number 9 in subtalar neutral, and here they are in resting calcaneal stance. Very little difference. If I did the shell game, you might have a hard time telling which is which. The only thing you're going to see is a little softening of the arch, a little soft tissue bulge here, but the arch really doesn't drop because it's not allowed to, because the heel stays inverted. Be careful about a false toe sign. Because this patient walks like a duck, it's easy to go, oh, look at too many toes laterally. That person must have a forefoot varus. But this is not a true toe sign. That's lateral hip rotation. So don't get caught in the bad habit of standing right behind the person. I'd have to go way over here to check the toe sign of the right leg, and I'd have to go way over here to get behind the left leg to check the toe sign of the left leg. You're standing directly behind, you might be fooled by hip rotation, thinking that's a positive toe sign. So I think we covered all that pretty well. And so we just discussed the number 9 foot type. And we just showed you this video, so I'm going to pass this one off. This is the one we just looked at. And I'm now going to go on to the number 13. Number 10 is the normal, I'm getting there. But the number 13 is it's the number 9, but because we're dropped down one row on that foot typing chart, that means we have a very small forefoot varus. It's usually no more than 1 to 3 degrees. But when it is in the 1 to 3 degrees on the foot type 13, that means their rear foot is pretty darn inverted. And that means the midfoot is pretty darn locked. So that means that 1 to 3 degree forefoot varus is probably pretty darn rigid. In the foot world, rigid things go with rigid things. So if your rear foot is supinated and rigid and your midfoot is rigid, then that forefoot varus is going to be rigid. So what you're going to see is when we watch this person walk, it's the same kind of overall look as a number 9 foot type. But what we're going to see is as the heel comes up off the ground, you're going to see a small medial heel whip. Why is it happening in propulsion? Because as long as the heel is on the ground, it controls everything. But when the heel comes up off the ground, we can start to compensate for that forefoot varus, and you're going to see that heel pivot. You see that heel whip towards the other heel? Sometimes these people will actually kick themselves, and they'll start to pivot to allow themselves to compensate for that forefoot varus and get down to the ground. So in order to compensate, whoops, that's the last video. In order to finish the job to compensate for the small 1, 2, 3 degree rigid forefoot varus, we have to go through that medial heel whip. It's small in the C-quad. It's a really quick ballistic whip. And other than that, these 2 feet are pretty much the same. Still have a nice stable lateral column, okay? Now let's get out of here and we're going to go over to the number 10. This is the ideal foot, right? The ideal foot is on this side of the chart. I think on this video, this left foot is more of a number 10. The right foot, I think, is possibly more of a 14. So let's all just pay attention to the left foot. And what you're going to see is when the heel comes down to the ground right away, let's go to heel strike. The heel is moderately inverted, and at foot flat, when the forefoot comes down to the ground, it loads pretty easily. We still have a pretty decent arch. It's not as high as the number 9 foot type because there's a little bit of pronation. This foot, instead of being stuck at 6 or 7 degrees like the other one, it's pronating down to minus, 4 or 5 degrees. And so the medial column loads easily. There's a little bit of drop in the arch, which is quite normal. Subtalar joint pronation is normal and necessary. And then when we go into propulsion, as the heel comes up off the ground, the first ray is able to load appropriately on the ground because the peroneus is stable, and that first ray can load up on the ground, no problem. And now we're seeing resupination as we go through propulsion. And that's exactly what we want to see. You see strike, heel strike, moderate pronation, load the forefoot evenly, stable lateral column, press off of that first metatarsal joint, the first ray, and final propulsion. And that is the very rare ideal foot type. so on the right foot, you'll see a little bit different. You'll see this one, we're starting to see too many toes laterally, right? So here we see a little bit more of that lateral forefoot. We can't see the big toe medially like we did. Let's go over here again and see. Oh, there's the medial toe sign is neutral. But on the right side, we're starting to see too many toes laterally. So I think that person was either born with a little bit of a forefoot varus or acquired a little bit of a forefoot varus, because forefoot varuses can be acquired as well. So let's go on to that foot type that we're leading into that we just saw here. That's the 14. And you can see in this case, the last case we saw, that right foot, I think it's a little bit of a younger in the evolution of the foot type. But this one here, I wanted to show this one to you because you're going to start to see the development of some hallux limitus and hallux rigidus from repetitive overloading of that first ray on a pronated forefoot. So you'll see some progressive changes in toe alignment and some intrinsic toe compensations. You'll see the toes gripping and whatnot. So let's go back one more time. So the C quad is the most common of the 4 feet. It's uncompensated more than it should be. It's rigid. It doesn't absorb shock well. It causes a lot of hip and back and knee problems. These are the patients I see a lot of because I'm a physical therapist and they think, oh, I need some help. I'm having a lot of chronic back and hip related issues. But how many people do you know are walking around with a sore hip going, boy, I need to get to the podiatrist? That's on you. You got to educate your patients. So a 9 and a 13, basically a 13 is a 9 with the rigid 3-degree forefoot varus, and a 10 is the ideal foot. That probably doesn't exist much in the adult population, because by the time you're the ripe old age of 19 or 20, you're already carrying around too much mass to sustain that. And so what happens? That perfect foot starts to push repetitive pressures on that first ray. It pushes it into a dorsiflex position, and eventually you can acquire that small, more flexible forefoot varus. The forefoot varus on this side is probably more flexible than I'm not going to say probably, it is. The forefoot varus on the 14 is much more flexible than the one on the 13. The 13, even if it's only a 2 or 3 degree forefoot varus, it's usually pretty darn rigid. So those are the differences in how I look at gait, and I hope that that gives you a little bit of an idea how to do that. I wanted to put up one more slide to show you that the C quad has that stable lateral column, and I know a lot of you don't know what I'm talking about on that. So I'm putting up a foot over here on the right in the D category, if I can get it where I want it to be, to show you one that is not stable. Let's see if I can get it to stop where I want it to. There we go. So here's a stable lateral column that we see on pretty much all the C's. We'll have a nice stable lateral column. But look at this one, then the D quad, that buckling. When your arch is pronated, when your heel can evert, when you are not uncompensated, you cannot have a stable mid-tarsal joint, and we lose the integrity, the stability and integrity of the lateral column, and that sets up disaster in the foot world. So that's just a comparison. So we kind of went over the features of the orthotic before. I like to have a moderately deep heel cup. I'm pretty deep on my heel cups. Most of my heel cups on my orthotics are 20 to 30 millimeters. Intrinsic rear foot posting, bringing the ground up to the foot, not wedging it more. Do not ask for medial skives. This patient will not tolerate a medial skive because they are already supinated. They're already, well, not supinated in the sense, but their heel is already inverted. And if you put a medial skive on there, that would be akin to giving them more medial posting and supinating them more. So if you have an orthotic with too much skive or any skive at all, you might hear your patient tell you, it feels like the arch is back too far on my orthotic. And that means a medial skive is probably there that needs to be removed. We're also going to talk a little bit about shoes. All right, I'm going to be moving on here. I'm going to go through this quickly. I'm going to go through the various, we talked about the number 9 being the most common foot type. So in the QuadraStep system, if any of you, can I see some more emojis? Who uses the QuadraStep system already? QuadraStep system, I'm not saying this because I invented it. I'm saying it because I love it. I make custom orthotics, and I just love doing QuadraSteps because they're same day dispensing often, and it's cheaper for the patient. They'll get multiple pairs, and they're a medical grade prefab, so they're made just like custom orthotics. So the number 9, the blue foot, is designed for the number 9 simply because it's the most common one that we treat. If I have a patient who is a number 10 or a 14, they have a more ideal foot or slightly pronated foot, and they may do very well with our new tri-step product. The tri-step product is going to be eventually 3 models. Right now we just have one, the tri-step yellow and the blue. Guess what? That goes for the yellow and the blue group. So the tri-steps model that we currently have available right now is a fantastic over-the-counter product. It has a intrinsic heel post, just like the QuadraStep, and it has cushioning under the heel because a lot of those people are chandelier shakers and they don't absorb shock well, so they need some heel cushioning. And it has some cushioning under the metatarsals because, as we know, those feet can have a lot of callousing under the met heads, or pressure anyways. So the tri-steps are probably a great choice. Much better, I think, than what's on the over-the-counter market now. Because if you take a look at typical retail over-the-counter orthotics that people can buy online, and what do they need you for anyways, if they can just buy them online? They're round on the bottom. They're round on the bottom and they don't control motion. They're basically just arch supports and cushioning. They can get that from, the retail stores or the online version. The QuadraSteps offers more. The QuadraStep orthotic is made to last. QuadraStep orthotics, if you're not familiar with them, will last the patient 3 to 5 years. So it's not a disposable orthotic. Tri-steps, I'm not going to attest to how long I think they'll last. I'm sure they're going to last more than 6 months because I've been wearing a prototype now for 6 months. So that's pretty good. But I don't think they're going to last as long as our QuadraStep orthotics, which are made more like a custom. The customs can be heat molded too. So you can put a little heat on them. I have a video. I'm not going to play it here because of lack of time. It's on my website, but it shows you how to heat and flare an arch using a standard heat gun and not to overheat it because you can melt it. So the number 14 foot type, the number 10 and the 14 might do well in the tri-steps. But if you were more worried about the 14 because it's an overpronator, you can use the standard C-quad and just heat it up and let it mold to the arch. Quite honestly, you don't really need to do that. If they just follow the break-in period, it will happen on its own. But some patients are like, I feel that. And I call this heating it up and molding it to their foot. I call that accelerated break-in. It would happen anyways, but it kind of gets them through the break-in a little quicker. Here's the tri-steps. It's on our website. This one, the blue and the yellow one, is now available, and the purple, green, and the red, orange, which will have some Forefoot posting on it, will be coming hopefully in the next 6 months or so. All right, so what the heck am I talking about when I say what's a super C or a super 9 or a super 13? A lot of those 9s and 13s, their heels are inverted like a lot, but some are really super inverted. And that's going to give them the appearance of a cavus foot. And that might be misinterpreted as an A quad. But an A quad will have callousing on the 1st and the 5th med head. And a super C will just have more callousing under the medial hallux. Well, how we manage that is we might need to add a little bit of forefoot posting to the C quad to address that rigid small forefoot varus. And that needs to be done as an inlay. Putting a little wedge under the inside of the orthotic on the distal end won't do the trick. It looks like I'm running out of time, so I'm gonna speed it up a little bit. Gravity will take effect. Here's a father-son, and you'll see when you have a young patient with the C quad, this foot's an E quad, but so the left foot is a C, and what you'll see is the arch drops down and the intrinsics start firing. We start developing toe compensations. Shoes, what kind of shoes do we need? We need a neutral cushion shoe to help absorb shock. Heavier or bigger patients might need a neutral stability shoe. I have some shoe recommendations for you. I like to see a very broad midfoot. I do not like to see this. My slogan is just say no to Nike. So this big cutaway in the instep here is not going to work for patients. My plank story I tell patients is if you had to walk across a pond on a plank, would you want to walk on a skinny plank or a big fat plank? I want to walk on a big fat plank because that gives me more surface area. And because these patients are over supinators, we need that lateral support, a nice lateral stabilizer. The Saucony Echelon and the Brooks Ghost Max 2 are some of my two favorite shoes. I do have shoe recommendations by models, as you can see here. And I have that all listed on a shoe chart. So if you want to write down my email, roberta@nolaro24.com, and you want a copy of my updated shoe chart, which I just is fresh off the press, you can email me and I will send you a copy of that. Last thing, and we're going to wrap it up and bring Ann back to the table, is we have a lot of education to share with you. If you go to my website, nolaro24.com, education, go to our education tab. You all just missed my master's class. Shame on you, because it was fantastic. We had 2 days with me and Lewis and Patrick DeHere talking about Aquinas deformities, but please do stay in touch. You can schedule a private or a virtual meeting or sign up for our webinars by contacting my assistant, Gina G, at nolaro24.com, and she can help you get access to our video library. There are fees for the webinars, but mostly they're free for the people that are using our products. I did it.
Great job. I did put Roberta's email address in the chat. So if you want to copy that out of the chat, you can, and you can send her an email. We have a question in the Q&A, and I'll get to that in just a second. But I just want to remind everybody who joined us a few minutes late, if you have any questions, because this is a lot of info and we covered it pretty quickly, type them into the Q&A box and we will get all your questions answered. So let's get started. What is your opinion on good feet orthotics as compared to custom? Are they custom?
No. So I do not think so. I know they're not custom. I'm not a big fan of the Good Feet store. I do not believe they have trained pedorthic or podiatry practitioners there. They're very similar, and they have these plugs that you put into them, but they're not made from a model of the patient's foot per se. They're not, I don't think they're specific enough. There's not enough uniqueness in the different models for the patients that I've seen come into my office. I think they're a little heavy on the sales. Like when a patient comes to my office, I downsell them. They come in for customs. I'm like, you don't need them. I'm going to put you in a QuadraStep. I just did that twice today. I'm like negative marketing lady. But I believe in karma. And I believe if you do what's right for your patient, they bring you more patients. So 2 patients today came to me for customs. They didn't have insurance coverage. I said, I got this. I got you. I'll put you in the QuadraStep. You're going to pay half the price. And I'm still making a pretty decent profit on the. Can I talk about pricing?
Of course.
Okay. So QuadraSteps cost you, for the people who are using our system and having our fitting kit, your QuadraSteps are going to be about $40. If you don't have them, you're just ordering one at a time, they're about $50. But the MSRP on them is $175 to $300, depending on what you're doing with them. So the markup on a QuadraStep, I'm telling you, you'll make more profit sometimes on a QuadraStep than you will on some of the reimbursements you might be getting from insurance companies. So I think the many custom orthotics are kind of cookie cutter. Every orthotic looks the same, and I put the Good Feet store right in that same basket.
All right. A good answer. How do you measure forefoot varus?
Okay, that's a complex. I'll try and show you. So if you're measuring it, so people will say, do you need to take goniometric measurements? I'm like, no, you don't. Why? Because when you have a patient standing, like look at this pediatric foot picture here. See how many toes I see? 2, 3, 4, 5 toes. When you see that many toes, that's a large forefoot varus. I can tell you, you can count the toes and know what your forefoot varus is. If you see 1 or 2 toes, that's a 1 to 3 degree forefoot varus. If you see 3 or 4 toes, that's probably a medium 4 to 6 degree forefoot varus. And if I write down +6 toes, like I think if they had another toe, I'd see that one too. That means they're a large forefoot varus. So the more toes you see, the bigger forefoot varus. But how I measure it is I have a plinth, a flat table like a massage table, and I have patients lie prone, and I put them in subtalar neutral, and I take a goniometer and I measure the angle of the plane of the metatarsal heads relative to the bisection of the heel. Happy to show you how to do that if you want to reach out to me privately. It's kind of hard to explain like this, but is it necessary? Probably not. And do I do it? Yeah, I do it on every single patient. And you want to know why? A lot of my patients, because I lecture a lot, my practice is in Connecticut. On any given day, none of my patients are from Connecticut. I get patients from New York, Massachusetts, Rhode Island, New Jersey, Vermont, Maine. So people will drive for a good orthotic. And if they drove that far, half the time when I'm walking them from the waiting room into my treatment room, I already know that guy's a 13. But I got to make it look good because they just rode 2 hours. So I'm going to take a whole bunch of measurements. I videotape them walking. I look at their shoes. Every single patient that leaves my office says, I never learned so much about my feet. And again, I spend a lot of time with my patients. I do spend an hour with my patients, but mostly it's just educating them. I already know what their biomechanical issue is in about 10 minutes. All right. Sorry, I can talk too much.
No, I love it. Here's a question about shoes. Why would you use the Ghost Max or any other over-cushioned midsole shoe for someone with a C or A foot type? I've only had failure due to these shoes allowing for breakdown along the lateral column of the shoe.
Yeah, because you're not using the right one. Let's say Hokas. There are some good Hokas, but the Hokas, I think overall, most of them are too flexible for this foot type. The Brooks Ghost Max is a godsend for anybody in the podiatry field. Just recommend that one shoe and you'll be golden. The Brooks Ghost Max is a neutral stability shoe. It has a stable heel counter. It has a lot of cushioning, and it has a forefoot rocker. So a lot of these patients have developed metatarsal discomfort. A lot of them have pain under the sesamoids or neuromas. You know, a lot of times they might have a neuroma. So that cushioning is there, but it's also stable. So it's a neutral stability shoe, in my opinion. Not all cushion shoes are great. I think a lot of them are way too cushioning. And like I said, most of the Hokas, I think, are too cushioning. But they weren't like that originally, but I think it's the, I don't know, it's on my list. Gaviota, I think, is more of a stable model in the Hokas. But I agree with you. You can use those more flexible shoes on smaller C-quads, you know, petite people that are in the C-quads because they're not going to bottom out, or less active people. But if you have a fairly active person, trust me, not the Brooks Ghost, maybe that's it. Not the Brooks Ghost, the Brooks Ghost Max 2. There was a Brooks Ghost Max 1, which was really, really good. But the Brooks Ghost Max 2, it's the best shoe I've ever seen.
All right. How does the amount of ankle joint Aquinas factor in when you start orthotic therapy?
A lot. If you have a patient with Aquinas in this group, they're really going to be tight laterally, like lateral gastroc, lateral head of the hamstrings because of the out toe walking. So they need to be doing stretching. I'm a big fan of Patrick DeHere's Aquinas brace. I recommend it to a lot of patients because I think one of my most famous sayings that I say over and over and over again is you can't correct something that doesn't have the flexibility to be corrected. So physical therapy, for the podiatrists out there, refer your patients to physical therapy. They're great at soft tissue tension. I have a patient that came to me today that is it's a young boy. I think he was 13. He is so tight. He's tight like an old man. and he's going to physical therapy, and I feel confident that he will get that worked out because I know the therapist that he's working with, and he will get that kid stretched out. So, and that's going to allow me to be more corrective with the orthotic and improve the orthotic tolerance. Because if I'm trying to this is true more for flat feet. If I'm trying to force a patient to walk straight on a really pronated foot, but they don't have the flexibility to be corrected, they're just going to slide off that orthotic. So less correction, to answer your question, start off under correcting and build up your correction over time. Sometimes if it's an older patient, it took them decades to get like that. And you got to recognize that you got to fix them over time, not overnight.
Yeah, it looks like that's the end of our questions. So if anybody has any last minute questions, you can type them in. We'll get them answered real quick. Otherwise, you can email Roberta directly and she will answer any questions for you. Also, of course, just like every other webinar we've done, and there are several from Roberta and Dr. DeCaro, you can access the recordings on our archives page. I'm going to put that in the chat right now. If you guys have any questions, feel free to reach out to Roberta directly. And I think our next webinar is actually not until June. And I believe it's Dr. DeCaro speaking about the pediatric foot. So we'll see how that goes. I'm sure it'll be awesome. Thank you, Roberta, for joining us. Thank you, everybody, for being online with us tonight. I appreciate it. And we look forward to seeing you all again.
All right. Appreciate your time.
Yeah. Thanks, everyone. Good night, everybody.
Bye-bye.
Bye.